It's our absolute pleasure to have you here today, to have you here over your lunch break, and to have a full room means that people are definitely excited about some new technology. My name's Rasha Alami. I'm from Imperial College in London. We are here for the CathWorks FFRangio Symposium, and it's my absolute pleasure to co-moderate this session with a friend and colleague, Ajay Katane from New York, and also to be joined by lots of other friends and colleagues, Carlos Colette from Aalst, Juan Iglesias from Geneva, and also Stéphane Fournier from Lausanne. So we're going to start by kind of talking a little bit about the objectives today. So for many of us, physiology, it has been important to our practice. But for most of us, it's been invasive physiology with the wire. And for most of us, that's all we've had available. We've used wire-based technologies for some time. We've become comfortable with them. But I guess we know that they're not always ideal. They have their limitations. And sometimes we're looking for new tools. And there's a real promise of new tools that are out there, and of course the FFRangio system from CathWorks is one of those. But I'm going to start by actually seeing what's going on in the audience. We're in Europe, where of course some of us don't have as much access to some of these new technologies as you guys have had in the US. So we'll start with a show of hands. So please put your hands up if you have an angio-based physiology system in your cath labs. Okay, so I reckon, what do you think, about 5–10% of the room? Not so many. Okay, how many of you, those of you who have angio-based systems, who's got CathWorks? Okay, even less. It's building though. Next year will be a different show of hands. And then finally, I guess, the show of hands is, who's here because they want it and they're interested in the technology and they'd like to have it in their labs? Okay. Are some people here just because they'd like a seat over lunch? Because they'd like to see Ajay?
No, they're trying to decide if they want.
They're trying to decide, yes. So maybe we start the conversation by going across the panel. I'll tell you, for my disclosure, our angio-based system, CathWorks, is coming in 2 weeks. We were hoping it would be in our hospital in time for this, but it's taken us a bit of time to get it, and in 2 weeks' time we'll have it in our cath lab, and we will be using it. Ajay, maybe we start with you, because of course the US has kind of led the way in really commercializing this. Tell us about your experience.
Yeah, I think, and we're going to bring this out in the discussion as well. Now, first of all, I'm also the spokesperson, which means I am your voice. There are microphones in the room, so certainly come up and speak that way. But if you send in questions into here, then I'll try to bring them into the discussion as well. We intend to have a lot of discussion. We were involved in the FAST FFR study, and that was the study that, and you'll hear a little bit about it, compared CathWorks specifically to wire-based technologies. And it showed that it was very accurate. But I will also tell you that I'm an honest person, and at the time we used it, I said, I'm not going to use this. The tech has to do all of it because it takes too long, and for clinical practice, it was going to be a difficult thing. As you know, we New Yorkers talk fast, we act fast, and so we also want to move fast. And that was a challenge. But the commercial version that we have now, which I actually do use routinely in clinical practice, is one where I find it fits seamlessly into the workflow and is saving time for me relative to using wires or anything else. And I also find it's very user-friendly in terms of the interface. Just for disclosure, I don't take any money from CathWorks, but I'm the study chairman of a trial you'll be hearing about, which is a randomized trial called the Allrise Trial, comparing CathWorks to conventional wires with clinical outcomes as the endpoint. But yeah, so that's my experience. Great to hear from other people.
Stéphane, maybe you can speak, because obviously you've been involved in a lot of the academic pursuit and the clinical use in Europe.
Yes, indeed. I started using CathWorks in 2017 when we included patients in a FAST FFR trial. I was in Aalst at that moment, and then had the chance to be one of the beta test center in Europe, and we had it for research in Lausanne. We had also the chance to have different softwares allowing to predict the FFR based on angiography, and we were able also to compare the different softwares. I will show you some data later. And yeah, I'm excited about the session.
Oh, thank you very much. And maybe now we can come to Juan, who's probably one of the, I mean, you've been flying, but one of the newer users in Europe. Can you tell us, I know you're going to give a talk about your experience, but a little bit about why you brought it into your lab and how the experience has been.
Well, we acquired the CathWorks system and the FFRangio back in December last year in our lab. We are using coronary physiology quite extensively as part of a routine practice. We're among the largest users of wire-based technologies in Switzerland. But we decided to move to these angio-derived physiology indices to overcome some of the limitations that we encountered in daily clinical practice. So we are using the software now since December, and we are really excited to be part of the Allrise study, and we are about to start the inclusion of first patients within the next couple of weeks. So this is basically our experience with the system.
Thank you. And Carlos, you've obviously got a lot of experience of the wire-based system, CT-based physiology. Tell us, what's your experience of the angio-based systems?
So with this particular system, we have been lucky enough to be one of the, let's say, first centers using the technology from the early beginning. And what is impressive to see, Rasha, is how this technology has evolved over time. You know, you got the first version that was a long time ago. Then you got the second version, and we're thrilled to get the new version as soon as, I think in a few months, we'll get the new system in the lab. And you see how this technology is becoming more relevant than ever before, helping us understanding the type of disease that we're treating, helping us guide the PCI. So I think this is getting better and better over time.
Fantastic. So, importantly, we'd like to encourage you to ask questions. Ajay is here to field your questions to the panel, but we'll come on now to the talk. So, Stefan, if you would mind starting, we're going to talk about the science. From angiograms to insights, where are we now with the science? Because for most of us, the clinical data drives our practice.
Thank you very much. Dear colleagues, dear friends, ladies and gentlemen, it is my pleasure to discuss with you during the next couple of minutes the science behind the FFRangio. I don't have any potential conflict of interest regarding this presentation, but I have been using FFRangio very frequently since 2017. Why is it useful to be able to predict, to calculate the FFR based on angiography as compared to wire-based FFR? Well, there are different advantages. You reduce the complications and the risks related to the invasive procedure. You don't need to cross the lesion and to manipulate a wire. There is a gain in procedure time. And here I have in mind all the cases of STEMI or non-STEMI patients that you do during the night, during the weekend. You are very often alone at the table. You just have to treat the culprit lesion on Monday morning. You can ask one of the paramedic, one of the fellow to calculate the non-culprit lesion, and you know if you have to bring back the patient to the cath lab or not. And this is extremely important to decide how long the patient will stay at the hospital. You don't have the cost related to the pressure wire, and you don't have the issue with the drug. You don't have all these issues, potential issues related to the measurements itself, such as the drift, and you don't have to manipulate this pressure wire, which sometimes can be somewhat quite tricky to manipulate. How does it work? Well, you know this conceptual relationship between flow, pressure, and resistance. It was a concept, but we published in 2019 that it's true also in humans. And you know that we can calculate the resistance based on the length and based on the diameter. CathWorks and FFRangio creates a 3D model of the total coronary artery tree. And then this 3D model will be analyzed as an electrical circuit, with each segment being analyzed as a resistor, and the resistance is calculated based on the length and based on the diameter. And then two models are built, one with stenosis and one without, and the comparison of the two models allow to predict the fractional flow reserve. In practice, how does it work? Well, there are 4 key steps. Everything starts with optimal 2D angiography. Then you have the reconstruction of the 3D model, the resistance analysis, and then you obtain this comprehensive physiological assessment. Step by step, step 1, you need 3 angiograms, and this is extremely important. This is the first step, but the most important one. You need different angulations, different views, 30 degrees apart. You have to select the end diastolic frame, but the software will help you to select the good frame. You need obviously a good opacification of the full tree, and you need a good view of the lesion and of the target vessel. The more views you have, the better you will understand what is really happening in the vessel. Step 2, the system generates this 3D volumetric model. It will help you to compensate for small motions that you could have. The system carefully evaluates each image using AI also, and you obtain this 3D volumetric geometry. Then, as I told you, the system analyzes every branch and bifurcation. It calculates the resistance to blood flow along each segment of the tree based on diameter and length. And as I told you, the system arranges their segments like resistors. This is what you obtain after a really short time. You don't have only one value at one point, here 58. You can click wherever you want and you have the value in every branch. This is extremely useful in the left side because at the same time you have the LAD, the circ, all the marginal, diagonal, whatever you want. And this is also something we discussed recently during a PCR webinar. When you plan your bifurcation PCI, you also have some very useful information. Here, for instance, you can see the view and you can prepare your PCI knowing in which view you will see your bifurcation very well. You also have some information about the length and about the diameter. It's not only FFR at one point. It's very nice, but does it work? Here you have some key studies. You can see that the accuracy ranges between 92 and 93, but our group in Lausanne very recently published an accuracy of 97. Some data about fast FFR. We included in this study more than 300 patients. Sensitivity 94, specificity 91, accuracy 92, positive predictive value 89, and negative predictive value 95%. As you can see on the left, there are very few misclassifications. As you can see on the right, there is no systematic bias. And here you have in blue the data related to FFRangio from CathWorks. On the right side, you have some data related to QFR. What you can appreciate on this slide is the fact that in most of the studies, the patient had a stable coronary artery disease. And the proportion of patients with a non-STEMI is extremely low, especially for QFR. This is something that we investigated recently in Lausanne. We can obviously discuss the role of physiology in acute setting, but in this study where we evaluated the performance of FFRangio in non-STEMI patients, we obtained almost the same result with an accuracy of 97%. You know that there are different softwares available. There has been a very nice publication by Carlos and the team in our Open Heart Journal. It was a network meta-analysis, so indirect comparison of different softwares. Here we did the first head-to-head comparison of the two softwares, FFRangio and QFR here. Same operators, same patients, same lesions. What we saw was a better correlation for FFRangio as compared to QFR with the invasive FFR as a gold standard. And if you look at all the different diagnostic parameters, they were all in favor of FFRangio, especially in terms of sensitivity and accuracy. Of course, this is a small study, but the data appears to be quite convincing. It was my final slide, and thank you very much for your attention.
Thank you. Fantastic. Thank you, Stefan. Maybe you can join us.
So we have a question from the audience asking about STEMI specifically. And so it's great you covered non-STEMI, but the question specifically is, how often are we finding readings where we look in STEMI and then they come back and it potentially looks different or value changes? Any thoughts on that?
It's true. It's a question that we have almost every day. I think we have also to admit that there might be a gray zone, that if you're FFRangio, you have a very borderline lesion and it's an LAD, young patient. You can also decide to bring the patient back to the cath lab. But of course, sometimes you have huge surprises when the patient comes back to the cath lab. But if it's really clear, your FFRangio values that you have a 92 or that you have on the opposite 0.55, I think that you can safely decide what you have to do with the patient. But obviously, we don't have any clear prospective data.
And remember, we're talking about non-culprit for the most part here,
exactly.
not culprit.
Yeah. So going back to the system, Stefan, and you briefly touched upon this, and all the data that you have shown is basically comparing a single point FFR with a single point FFRangio, and their correlation looks pretty good. But you also mentioned that you have the ability to understand how the pressure is lost over the vessel. This is what we call the pullback curve. So you get some sort of a virtual pullback curve along the complete vessel, and that helps you decide first whether there is a case for PCI or not. And we're starting to understand that patients with diffuse coronary artery disease are not the best candidates for PCI, and the ones with focal functional disease are the best patients for PCI because those we can't really improve flow. So any comment on how you're using this pullback curve in your practice?
It's true that we have all these new publications related to this new index, the PPG, and I am not aware of any formal comparison about the between the pullback that we have with FFRangio, the virtual pullback, and the PPG. But it's true in my experience that what I showed you on the right side of the slide, when you see the pattern, you can already have a good feeling. And when you measure your PPG in real life, you obtain almost the same results. So when you have a clear focal lesions with FFRangio, you will find it also invasively.
Yeah, I think one of the things with this technology is that, if you ask any, hardcore physiology person, and remember, meetings historically for interventional meetings, there are physiology sessions, and people who love physiology go to those sessions. But those folks will all say you have to do the pullback to be able to sort out what's going on. And that's true with FFR, that's true with non-hyperemic indices, where maybe even more advantageous because you can actually isolate individual lesions. But the reason people don't do it in practice is because the only people, in those sessions, it's a small group of people because the masses find it too annoying and painful to zero and equalize. And I'll get into this in my talk. One of the nice things about these types of technologies is they sort of make it easier because it just shows you what you're dealing with. And of course, if you see a focal drop in the FFR and that corresponds with a change in the QCA, that makes sense to stent. If it's diffuse throughout the entire LAD, then you're not going to be helped by stenting one focal lesion. And so by presenting it in easy to read format, much similar to things like heart flow, you can actually look at it and plan your case in a very intuitive way, not just for those that are hardcore physiologists.
Yeah, and Stefan, I wanted to ask you, so for those people who, like me, who's about to get it in my lab in 2 weeks' time, what's the learning curve in terms of training, and how many cases do you think you need to be totally happy?
We did the study, so it's under review now, where we evaluated the learning curve of both FFRangio and QFR. We had a group of paramedics, students, and cardiologists, but not trained for a cath lab. What we saw, it was a little bit a surprise for me. The performance is extremely good from the beginning after a very short training. So in terms of performance, as compared to the invasive FFR, it's a plateau from the beginning. But the time is, I think after 20 cases, you are extremely efficient, and we observed again in terms of time to measure it. So performance is good from the beginning, but this is extremely reassuring for an hospital because you can trust your team from the beginning. But at the beginning, it will last 1 or 2 additional minutes as compared to the experience after some experience.
Fantastic. So I think we'll move on to our next talk, if that's okay, and we've got loads more time for discussion, and please send your questions through. So Juan Iglesias will talk to us about the European experience of integrating FFRangio into clinical practice.
Thank you, Rasha. Ladies and gentlemen, dear colleagues, my great pleasure to present you on our minimally European experience integrated FFRangio into clinical practice. And as you will see, I will come back to some of the points which are discussed and the potential of this technology to improve the workflow of the patients we are treating in daily practice. These are my disclosures. So we already saw this slide, but I think this is an important slide even for me to explain the rationale why moving from a pressure wire-based physiology assessment to an angiographically derived physiology assessment. So despite, as you know, having the highest recommendation in European guidelines, the adoption of wire-based FFR in clinical practice remains pretty low, and it's very low in Europe and low in Switzerland. And as discussed already by Stefan, there are several limitations of pressure wire-based FFR, of which several have been addressed partially with the introduction of non-hyperemic pressure ratios. There are still some limitations of this technology that are still present in daily practice, the manipulation of the wire and the difficulty in some complex anatomy to assess the coronary artery lesions that we see on the coronary angiogram, and this is relatively important when we consider the increasing proportion of patients with complex coronary artery disease treated every day in our cath labs. and mostly the complexity and the issues with measurements, as discussed by Stefan previously, which are actually very important in clinical practice. And I'm talking here about patients with multivessel coronary artery disease, where currently we do not have any other option than perform multiple wire-based assessment, as in these patients, 5 measurements, which increases procedure time and increases for each wire manipulation the procedural risk. But there's also the possibility, actually, with this new technology to assess and understand the coronary artery lesion pattern that we are treating. And as mentioned by Carlos, it is something that's pretty new in the field of invasive coronary physiology, but which, as I will show you, is something we can derive now currently with these angio-derived pressure assessments. So this is true for focal diffuse disease, but this is also true for terminal lesion. And this is related to the hemodynamic interference of coronary lesions that we are assessing. We have currently several modalities. We talked about IFR pullback and the newly introduced pullback pressure gradient by Carlos, presented here at EuroPCR. So these are the tools that we have. So what can we expect from angio-derived FFR technologies, and mainly FFRangio? So beyond, I think, the number of the FFRangio value that actually has a high accuracy when compared to invasive FFR, as shown by Stefan, there are several other things that we can derive from FFRangio. And first is the 3D vessel reconstruction model that allows the entire coronary tree assessment. And this is something quite unique with this technology when compared to other angio-derived FFR indices. And this allows multi-vessel coronary artery assessment, but also side branch assessment in bifurcation lesion. On the right side of the panel, you have a longitudinal vessel analysis that allows you to understand the pattern of the coronary artery disease that you are treating by distinguishing between focal and diffuse functional coronary artery patterns, and understand tandem lesion assessment, which of the lesions that need to be treated and which can be deferred. Let me discuss with you 2 clinical cases that we recently performed in our cath lab, just to understand how this technology can be applied in clinical practice. So this is a 79-year-old female with hypertension. We presented to our center with a de novo chest pain, as shown as a breath, with a left bundle branch block, troponin rise, and on the echocardiogram preserved LV function with inferior infraseptal hyperkinesia. So she referred to us for a coronary angiogram for a non-STEMI, and as you can see here from the angiogram, we have a 3-vessel coronary artery disease with a long diffuse mid-LAD stenosis. We have as well a focal stenosis followed by quite diffuse disease on the proximal to the OM branch, and on the right coronary artery, a very long diffuse disease of the right coronary artery on mid to distal segment, as well in the PDA and PLV. So angiographically, we are facing here significant 3-vessel disease with apparently long and diffuse coronary lesions. So in this patient, what we discuss is, to provide additional information that angiography cannot always provide, which is a functional assessment of coronary lesions we are assessing. So this has been shown to be of high accuracy in a small study, which compare FFRangio with wire-based FFR in patients with 2 and 3 vessel coronary artery disease. This is a 50-patient study with 118 lesions, showing not only the high diagnostic performance of FFRangio when compared to FFR assessed by a pressure wire with a 93% diagnostic accuracy per lesion analysis. But on the right-hand side here, you can see that the difference on the Blunt-Hartmann plot is very small when compared to the invasive derived FFR with a 0.02 difference, which corresponds to a Pearson error value of 0.83, confirming the high correlation of both methods. So we perform FFRangio on the LAD, which actually provided a value of 0.64, which is below the cutoff, as you know. On the right side here, in the longitudinal vessel analysis, you can see that this corresponds to a focal disease located on the segment of the mid-LAD. On the circumflex, and this is derived from the same angiogram, perform off record without the need of a pressure wire, we have a value of 0.68 as well. Focal disease located on the proximal segment of the circumflex. And on the right coronary artery as well, a highly significant, hemodynamically significant lesion, which corresponds to a focal lesion on the mid segment of the right coronary artery. So this is basically a 3-vessel disease. This lady was presented during a heart team discussion, and due to the low functional syntax score and the bad target on the LAD, we went actually for a percutaneous coronary revascularization, which was performed as stage procedures. So this is the right coronary artery PCI, which was fixed with 2 drug-eluting stents, and we perform FFRangio to assess the complete functional correction of the pressure gradient, and we have a value post-PCI of 0.91. Then we went on for the stage PCI over circumflex, which was fixed with 1 drug-eluting stent. Again, the FFRangio value was 0.93 post-PCI with complete resolution of the focal pattern which was present on the mid-segment of this coronary artery. And then we perform an hybrid PCI to the LAD with a drug-eluting stent on the proximal segment and a long DCB distally. And we perform as well FFRangio after the procedure, which showed actually complete resolution of the hemodynamic compromise with FFRangio 0.92, and as you can see, just a small focal lesion distal to the lesion which was considered for medical treatment. So we offered actually the patient, based on this technology, a functional complete coronary revascularization, and I'm glad to hear that actually at 3 months she's completely symptom-free. Another case which could be of interest is the use of FFRangio in lesions which present with tandem or serial patterns. So this is a 71-year-old male with diabetes, hypertension. We presented again with a de novo chest pain, this time a right bundle branch blocked. Some troponin rise, a normal echocardiogram, and the patient was referred for a non-STEMI. And as you can see here on the angiogram, what we found actually is a tandem lesion on actually 3 lesions on the LAD located on the mid-segment, and more distally 2 lesions, one that seems more focal, and another lesion more distally with unobstructed coronary arteries on the circumflex and on the right coronary artery. So this was basically based on angiogram, a significant secant vessel disease with presence of tandem lesions in the LAD. So this is the FFRangio, and as you can see very nicely, what we could identify is that this was mainly related to a focal disease at the level of this lesion. As nicely shown by Stefan previously, you can identify with the 3D reconstruction model the location of the focal lesion you are treating, with minimal compromise related or implication pressure gradient from both the 2 lesions located on the proximal segment on the distal segment. So we went on for a full DCB treatment, just focusing on this distal lesion here, leaving alone the proximal and more distal lesion. And as nicely shown here by the FFRangio performed at the end of the procedure, complete restoration over normal physiology with a FFRangio 0.93 with a small pressure gradient distal to the lesion that was considered non-significant hemodynamically and left for coronary for medical treatment. So, ladies and gentlemen, my conclusion regarding our experience with this technology: the routine use of invasive coronary physiology indices in clinical practice is still hampered by persistent technical limitations and complexity of current wire-based technology. And FFRangio represents in Europe a novel and promising alternative to conventional pressure wire physiological lesion assessment, and which has the potential to further extend the adoption of routine coronary physiology guidance, including the management of challenging lesion subsets. And with that, I would like to thank you for your attention.
Thank you so much, Ron. So I might start the comment. So you showed us 2 fantastic cases. And let's face it, especially that first case, this was testing the technology to its limits, really. This was a very complex complex multivessel disease case. But maybe you could talk to us about the use of post-PCI angio-FFR, and do you think that that's a real place where we might start to use more and more of this, because that's often a moment where we don't want to take the wire down again necessarily if we haven't used it for our PCI?
Yeah, that's a very good point, Rasha. As you know, we are, on a learning curve, at least at our center, in using technology in these settings. We do not have currently data to support actually the cutoff that we are using for FFRangio post-PCI. We are using the cutoffs that have been derived from the FFR studies, which actually, something that I did not show in these cases, this was part of our learning curve, so we're doing as well invasive measurements to correlate and actually it worked pretty well. So even if we can see the hyperemic indices like FFR, which has been validated in the post-PCI setting, we were very close to the values that we actually derived from the angiography with FFRangio. But I think that this is a nice indication for the technology as far as we can provide in the future data, I mean, showing that it's safe to derive according to the cutoff that we are using these lesions.
I think it was also a really nice demonstration of the fact that most people, when they see anatomy like you showed in the first case, they think imaging. If they think anything besides the angiogram, they think imaging, and imaging is going to be important to optimize. But most people don't appreciate the value that physiology can add in selecting and parsing out which the lesions are significant. And so, both cases were very complementary in that way and super, super helpful. We have
I think this is an important point. There's some algorithms that are coming out in literature, and one recent published in Eurointervention, creating an algorithm on how to assess our post-PCI results, and it's clear that this technology has a place, and in case of suboptimal results, that imaging could be actually very important to complement the physiologic value, to understand the reasons why our pattern, for example, of FFRangio post-PCI may show some focal or somehow diffuse disease. So, these are complementary. We still need to determine which is the place for this technology in this setting, but it's really promising.
So we have a question from the audience. Effect of microvascular dysfunction on FFRangio. Maybe Stéphane, you want to take that?
We had a discussion yesterday with the team of CathWorks. I know that a lot of work is being done to study the performance of this kind of software to evaluate the microcirculation. So far, we don't have any data. I had a comment to do about the first case. I think if you think about your real life in the cath lab, it's a case of trivial disease. Imagine yourself. You arrive in the cath lab in the morning. You have plenty of patients, a lot of non-STEMI during the day, a lot of patients from the outpatient clinic. If you tell your team, I will start measuring FFR in all the vessels, your colleague will kill you.
Pre and post.
Here, it's the advantage that you just take the good images, then you end up your procedure, and you have the entire day or the entire week to calculate slowly, taking your time, the different FFR values, and you have time to do it before the heart team. It is a huge advantage.
Yeah. Back to the microvascular question, remember it's a QCA-based index also. So if anything, it should be less modified by the effect of microvascular dysfunction. But there's also potential to be able to use this in the future to identify microvascular dysfunction, which is what Stéphane was kind of getting at. So stay tuned for that. One question on modification of your angiography. I think what you showed nicely is that typically the zoomed out views are going to be best. You typically want to have the entire artery filled. So you maybe decrease the mag by 1 and no panning. It can work with panning, but it's easier to do without panning. And so for our institution, because we're used to doing CTO type cases, we just take everything on a slightly lower mag without panning, and it's useful. But one big limitation of the technology is if you don't see the lesion on the angiogram, it's going to be virtually impossible for any angio-based technology to get you a derived FFR value. So good angiography is important. You have to see the lesion, and you have to typically see it in a couple different views to really be able to maximize the technology. Okay. Carlos, any comments on that?
Well, I think that we're coming back, to doing good angiograms, even in the acute setting. I think, coming back and analyze the non-cooperative vessel after non-STEMI, I think is a perfect niche for this technology. But also in the, in day-to-day practice, you have a moderate lesion, you just analyze it with FFRangio, and then you get the result. Now, what I'm seeing, AJ, is that we are progressing slowly to 100% physiology uptake, because this is becoming so simple. And it's just, shoot the angiogram, you get a good projection, then you get physiology. So I think in the future, we'll not be talking anymore about what is the uptake of physiology, because it's going to be so easy. It's going to be in front of you in every single case, after every single angiography, that physiology will be 100% used in everyday clinical practice. And I see that coming.
Sorry, we have a question back there. Sorry, I didn't see you before.
That's okay. Very interesting technology. I have two questions. One about the frame rate where you are taking the angiogram. We're usually in Denmark, we're using 7.5. So is it required to have 15 or 13 or 30? Because the area experience was required to have 30. So that's for radiation?
It can be done with 10 or greater for Cine, but it won't work on a stored fluoro, but a Cine 10 or greater would work. Go ahead.
The second question, if we have two stenoses and you have the pullback and both seems moderately significant, is there a computerized algorithm to predict which one would be better to treat?
It's coming.
Or what's
It's coming.
It's
Watch
coming.
this space.
But right now, you can see it on the pressure pullback curve. In the case that was shown, you didn't see it for the distal stenosis, but if you did see it, you can actually see. But the algorithm for predicted virtual stenting and everything else like that has to go through some approval, but it can be done.
Yes, because what we are seeing in everyday life, it's sometimes you predict or you think that one of them is more significant, and when you do the one which is more significant, it is still significant for the other one.
Yeah, and
So
I
it's,
would personally, my opinion on this, and this is not based on fact though, is because this is derived by QCA and algorithms of resistance, it would be less prone to the interdependence of lesions than traditional wire-based technologies would be. So,
Thanks.
So, in the interest of time, I think, can you tell us, please, Ajay, how we established FFRangio as the new standard of care? It's quite a title.
look, I'll try. I think that I want to definitely take a step back because we saw complicated cases, we saw what it can do, but we do need to go back and remember that when we leave conferences and we see great sessions, we end up going back to our clinical practice, and for most clinicians, they learn a few things, but they kind of go back to their routine care. So let's talk about what routine care is and then how we can change it. So I'll start off with this case. This is a patient that was referred to me by one of our cardiothoracic surgeons. It's a neurologist. He was generally asymptomatic, but they were concerned about him going for a procedure, and so ended up with a stress test that was abnormal, and he had this catheterization done. The angiograms are not perfect. They're done at 30 frames a second. It's probably not something that I would do right now, but there's a stent here. There's moderate disease in the LAD, moderate disease in the circumflex, moderate disease in the right coronary. This is the picture I wouldn't advise taking, but it looks like that the ejection fraction is generally okay. And what happened in this case is actually the patient was referred to our cardiothoracic surgeons for consideration of surgery. And I'm not joking. This is what the cath report read. 50 to 55% left main, some LAD, some diag, instant restenosis, and some circumflex disease. And the CT surgeon, who's the chief of CT surgery at Columbia, called me up and said, isn't there some wire-based thing that you do that you can figure out? Because I don't really see why we should send the patient to surgery. So what I ended up doing is I saw the patient. Clinically, he was generally asymptomatic. He needed to go for a procedure. He had pretty prominent ST depressions on his stress test. And so this is before FFRangio. So I took 2 guides, 3 vessels wired, 3 rounds of adenosine. Nothing was significant, so we deferred the CABG, deferred the PCI. He's back in clinical practice, and he's still practicing 5 years later as a very asymptomatic neurologist, and he had his procedure okay. But this was a bit of a pain to do. Multiple guides, multiple wires, and when I saw the case initially, I was like, we both knew, myself and the chief of surgery, the guy didn't need anything done, but yet this was occurring because nobody had thought of it at the time. So the question comes up, do I need to do physiologic lesion assessment on every case? And traditionally with wire-based paradigms, the way I like to teach about this is I think that there's a clinical scenario. It's generally going to be stable ischemic heart disease, not the ACS culprit. It could be the non-culprit and non-STEMI, et cetera. You correlate that with the non-invasive testing. You correlate that with the coronary angiogram, and all 3 of them together make a story for the patient. So if the patient has typical chest pain, a positive stress test anteriorly, and a 70% lesion, you don't have to do physiology in those cases because everything is concordant. So usually with wire-based technologies, what we do is we think about physiology when there's missing data, equivocal data, or discordance between these things because the story doesn't fit. So we want to adjudicate something based on a wire. But the problem is first of all, that limits our use of physiology. And second, because physiology is a pain, it's underutilized. And so I've heard many things at conferences along the year, and some people just say, look, I know better if this should be treated or not, because that's why I don't want to use physiology. They say I'm an experienced catheterizer and angiographer, and I know better if this should be treated or not. They say, look, the data are flawed, it's old data, it's just, it's too small because they know better. They say, I don't really believe the number anyway when I get it because I know better if this should be treated or not. Or they say, I just want to treat the lesion and I don't want to be held back by some number because I know better if it should be treated. And finally, they say, it's just too painful to do it because I know better if they should be treated or not. So a good friend and colleague of mine, Dimitri Karmpaliotis, has a great expression that he can make when somebody just says something that doesn't make a lot of sense. And this is sort of the expression. I mean, really, is this really why we're not doing physiology? I think the real reason is because the last one, it's difficult and painful to do in routine clinical practice. So there are also problems with it. And people will say, well, what about the inaccuracy of CathWorks or any of the other angio-based FFR systems? Well, there's plenty of inaccuracies with the wire, and you have to be meticulous. If you move the transducer around, if you wedge the guide in, you can change the pressure waveform. This was made in a live case at PCR where somebody did the FFR with the wire introducer in. If you want to fudge an FFR value, there are plenty of ways to do it. You can shake the wire, you can do all kinds of stuff that people shouldn't be doing, but people yet will do in clinical practice. So for me, what I basically think is this could just be done in an easier fashion. And that's the whole point of using an angiographically based system to be able to do it. So this is a classic case of an 87-year-old woman. She had risk factors. She actually had a negative SPECT stress test 6 months prior and had gradually worsening symptoms despite escalation of medical therapy. So she came to the cath lab, and this is just an example of a low MAG angiogram without panning. And what you see is there's an intermediate lesion in this mid-LAD. If you really believed her symptoms, there are people who would just say, just stent it. If she didn't have typical symptoms, some people would say, leave it, but why not figure it out and do physiology of it? But I don't necessarily need to do that physiology with guides, wires, and everything else. What I can do is do FFRangio. So with those 3 views alone, my workflow in the cath lab is I take the angiogram, I see that lesion, I call for the person to come in to help. We in our lab, we have a tech, but you can do it yourself if you want to. It's automatically transferring images to the console. And if I scrub out, the images are there. I can pick the images I want. I pick these 3 images, and within 2 minutes after that, it gives me what the number is. I didn't have to take a wire, I didn't have to take a guide or anything else like that. And what it also showed is that it was relatively focal at this point. This is the example, the pressure pullback curve, where you can see the drop in pressure. The pressure loss is at this point right here. But there's also a QCA pullback curve, which is this. And that shows that certainly the vessel, the LAD, tapers as you go distal, but the drop in the LAD is right here corresponding to that drop in pressure. Note that there's also, you might not even have noticed it, but there's sort of this intermediate thing here as well, proximally, that's close to the bifurcation of the diag. If you went to image that, you might see plaque there, and people who don't know how to hold back might be tempted to do bifurcation stenting. In this case, just because you see the QCA drop, if I go back a slide, there's no or minimal pressure drop there. I don't need to treat it, I just treat the mid-LAD. There's also the sizing tool, which you can use to then bring over. And if you sort of say from here to here, that's where I'm going to fix the QCA change, which is corresponding with the pressure loss, it would basically be a 20 millimeter stent. And by the way, it also gives you the QCA, so you can kind of do a virtual stent at that point, determining that the stent size should be 3.0 because this is measuring out to be 2.8 millimeters. So this is the stent placement. We pre-dilated, put the stent in, 3.0 by 23, pretty much exactly what was prescribed by the technology. Here's the final angiogram. We stented it simply. It's a type A lesion. Why am I showing a type A lesion at PCR? Because we're talking about generalizing this into clinical practice. So we saw the complicated things. This is very simple. But then you get a free look without any other wire manipulation at what the post-PCI physiology is. And by the way, because we do image-guided PCI for virtually all of our patients, we checked it with OCT, and the expansion was great. Everything looked fine, and I'm not going to show you the OCT run. So in summary, what we have now is a situation where there's great data supporting physiology, but it's just frankly underutilized. And no matter how many symposia we go to, how much data we show, it's underutilized, and we have to figure out why that is. It's not because of lack of data, it's because it's difficult to do. So the idea here is to uninterrupt your workflow. Don't use unconventional wires to try to wire things multiple times with guides, et cetera. You don't have to use vasodilators. There's technical issues with the wires as well. And potentially, you could basically do this in cases to get multiple vessels, no vasodilators. It'd be faster, could be less costly, but there is training needed. This is not something you just put in the lab and start working on day one. I always tell sites that they should start messing around with the images, see what changing the image does to the FFR so that you feel comfortable using the system when you have it for the first time. Now, That's all great and fine for me to say, but we want to prove it. And so the Allrise Trial is a randomized trial of almost 2,000 patients where patients are coming in and being randomly assigned to an FFRangio-based strategy versus a wire-based strategy. We're looking at clinical outcomes associated with it, and we're also looking at cost and equivalent utilization associated with it. And so the idea here is to show benefit in this way. Rasha is participating, and we have folks on the FFR side, the IFR side, clinical people. It's going to be helpful, and we've already enrolled 400 patients. So with that, I'll conclude, and I know we have to wrap up the session, so we can maybe take a couple time for comments. Thanks.
Fantastic. Thank you, Ajay. So maybe we just take one or two of the questions from the audience just to wrap up. One of them is, are there any situations, maybe I give it to you, Ajay, any situations where you would pull out the wire and you wouldn't use this technology?
Yeah, so one question came up was post-CABG. This has not been validated in post-CABG, and the reason is that you need a complete coronary tree to figure it out. So that's a situation where I would. We're also enrolling in clinical trials like defined GPS, so those are cases. But virtually all my cases where I'm using it for diagnostic purposes and the imaging is good, I'll tend to use the system first.
Fantastic. So maybe, Ajay, you could give the final word to the session as we wrap up. I think it's been a fantastic session, loads of interaction. Maybe you could close.
No, I think so too. And I think we really went from the basics, which are what the technology is. Hopefully you understand some of the data behind it, to how it can be used in simple cases like I showed, complex cases like Juan showed. We heard about the future as Carlos envisioned. And I think that future is coming soon. So, for all of you, thanks so much for attending. Rasha, again, phenomenal job as always, and really appreciate it. We'll stay back for questions after the break. But again, thanks everybody for attending.